We've had quite a lot of questions in. I have tried to group them together into themes, if you like. And I just want to begin by recapping on some of the key points that you were mentioning in the video, so that if people didn't quite catch it all, we can just clarify that. So first of all, can you just explain again why we've moved on from having a patient choice arm?
Yeah, I know, Hilary, that's a very important question, really, in terms of when we initially developed a trial and we had to go through the approvals of the study protocol with the health authorities as well as the sponsor of the study as well. We had this cohort which was called the patient choice cohort, but because it's a randomized trial, one of the objections was that why we need a patient choice cohort. And the main question that we're trying to answer here is if we have patients who have ibrutinib for such a long time, which is about 6 years of therapy on FLAIR, and patients who've had relapsed disease must have had treatment for more than 3 years. And if the disease burden is very low, whether we stop the therapy and then see what happens, or we just continue the therapy. So in the randomized arm of this trial, where half of the patients will continue the therapy and the other half of the patients, where I mentioned the concept that they don't have any active disease at all, will be able to stop therapy. And even in that intermittent therapy cohort, what will happen is that if the disease starts to progress, as Pete was mentioning, that the lymphocyte count starts to go up, then they will start the therapy again, and then we will monitor how the things evolve over time. But there would be a group of patients who will have 6 years of treatment, and or they have 3 years of treatment in the relapsed disease cohort, where the lymphocyte count would be above 5, or they might have other evidence of active disease. And if we feel that that's not appropriate to stop therapy in those patients, and those patients will go into this cohort, which is clinical need cohort now, because these patients do need the drug clinically, whereas this patient choice cohort has been taken away. And that was one of the objections from the sponsor, well, not the sponsor, but also the health authorities to essentially get the approval of the study. And we believe that, it is an appropriate thing to continue treatment in patients who've got active disease. But in patients who do not have active disease, we are trying to answer this important question of intermittent versus continuous therapy.
Thank you. And can you just recap on which patients from the FLAIR trial are eligible to go on to static, including the ones that have finished the 6 years on FLAIR?
Yeah, so the FLAIR study started in 2014. So we have those early patients who would have finished 6 years of therapy, and they may be off the drug for nearly 1 to 1.5 years already. And those patients are allowed to go into static study. So they are eligible for going for recruitment into static study. And anybody who's coming off therapy in FLAIR study and had 6 years of therapy will automatically be able to roll on to static study, depending on what is the disease status at this moment in time, whether they go into the randomized arm of the trial or whether there is this clinical need cohort. So yeah, virtually everybody from FLAIR study, I can reassure, can move on to the study, providing there is no other reason why patients cannot go into that study, such as side effects, or if the disease unfortunately has progressed. In that case, that would not be appropriate. Virtually everyone else.
And if, having been on FLAIR for 6 years, if the disease has begun to relapse, the condition has begun to relapse, then they may not be able to go on to static. That's one of the reasons you're saying that it wouldn't be possible.
That's true. And in patients who've stopped therapy and their disease is just starting to show signs of progression, then we can look and do the screening and see if that is appropriate for patients to go on to static study. And that would still be a relevant question to answer. But it may be that they go into the clinical need cohort, which I was saying about the active disease, which would be an appropriate thing to do for those patients.
And if patients have developed comorbidities since they started the FLAIR trial, would they be able to go on to static as well?
Yes, they would be able to go into static, but we will have to ascertain the comorbidities, and in the trial protocol, as well as what we call as the screening period of the trial, there would be some assessments which will be done, and comorbidities would be assessed at the same time. So say, for example, if somebody has developed high blood pressure and they have been treated appropriately with blood pressure pills, then they would be able to go into the study. But we would have some recommendations for the local team to make sure that we properly assess the heart function, and some of the tests might to be done. But overall, even if people have developed comorbidities, the trial will look. There is all that information included in the trial protocol to ensure that these patients, if they can go into the study, they will be able to go into the study.
Excellent. And we're talking about people going from FLAIR onto static, but of course, a lot of the people going into the static trial will be coming from where they've been taking ibrutinib as a second or subsequent line of treatment. So can you just confirm about that other group, because we don't want to just talk about the people from FLAIR.
That's absolutely right. So the patients, we know that ibrutinib is an approved drug for patients with relapsed refractory CLL. And that means that if somebody has had one treatment before and then they got ibrutinib, then they had two or more therapies before and they got ibrutinib, and those patients would be eligible to go into the study. But there are some restrictions that patients need to be on the drug for at least 3 years. And the reason for that is that we know in the relapsed refractory CLL that patients who only had 1 or 2 years of therapy, they still have got quite a bit of disease there. So what we want to do is that the disease bulk, the amount of disease that is present in the bone marrow or in the lymph nodes, is very, very small when they go into static study. And that is one of the key inclusion criteria, that patients need to have 3 years of therapy in the relapsed refractory cohort before they can come onto and enroll onto static study.
And so does that mean that there'll be some people that aren't eligible to join static now, but they might be eligible to join it in the future?
Yeah, so the study is going to be rolling over to up to 6 years. So there is ample time to actually participate in the study. And somebody who's at 2 years of therapy of ibrutinib, maybe at 3 years time point, would be absolutely eligible for static study at that point. Excellent.
And you were talking about, or Peter was talking about, 400 in the continuous arm and 400 in the intermittent arm.
That's true. Yes, so that's the kind of randomized control trial that we do, and half is how the patients would be allocated. And it's a toss of the coin, really. The computer decides which arm of the trial you would be going into, and we wouldn't have any control over that. But that was the same with FLAIR study, or any randomized control trial is done in such a way that I'm not able to make that judgment which patient needs which therapy. So that's the whole point of a phase 3 trial.
Thank you. And then we've got, unsurprisingly, some questions about timing. So first of all, when is static going to open in the first hospitals?
So the good news is that it's all approved now, and the Leeds team, CTRU team from the University of Leeds, is trying to get the trial open in multiple centers. So what happens now is that individual hospitals will be sending a paperwork so that they can open up the studies. Now, because I have to mention the word COVID, because due to the pandemic, the research teams have been under a lot of pressure. and a lot of research staff was reallocated to do COVID research, and now things are starting to open up. So what we're finding is that it is taking a bit more time for individual hospitals, which were FLAIR participants, are taking a bit longer to open up the studies, but that is understandable. What I would say is that we are trying to open as many sites as possible, and hopefully all the sites that were open for FLAIR, which hopefully in time be open for static as well. Now, if you have got a site which is not opening up soon for static, there may be a possibility that the trial may be open in a near vicinity hospital where patients can move on to and get enrolled onto static study as well.
And then they might be able to move back to their own hospital later on.
Yeah, that's absolutely right. As soon as that study gets open in the local hospital, we have got that flexibility to move the patients back into their native hospitals.
Mm-hmm. And how would individuals go about applying to join static?
So I think what I would suggest is that the first thing to do is to contact your research teams and get an estimate of when the trial is going to open. Some centers are already kind of in process of opening, and I think we are every hospital can give you an estimate when the trial is going to open. Once it's open, what they will do is they will send a patient information sheet to the trial participants, and then hopefully they can consent you and then get you onto the trial. So I think contacting the research team, speaking to your consultant who has been looking after you, the local PI of the study would be able to give you that information. What is the rough estimate to get that study open in that individual center?
Thank you. And if people on the FLAIR trial, will they have to give their consent again for static?
Yes, that is true. For any study that we do, we have to get you sign the consent form again, because the question in static study is different to what we were looking in FLAIR study, where the question was, is ibrutinib a better therapy than FCR, or there are other arms of that study. So when you move on to a different study, this is a different question now with different information, and we have got a lot of information that has come through now about ibrutinib and how we want to conduct the study. So unfortunately, Hilary, that answer to that question is yes, that we have to consent you again.
But at least they've done it once before, so
yeah.
Yeah. So when a trial opens, this use of the word opens, how long is it open for? And when you join it at the very beginning, do you then get your treatment? You don't have to wait till the lists are closed before it all starts. It's a continuous process.
Yes, it is a continuous process, and the opening of the trial means that this trial can open in various sites in UK. So we have got the ethical approval, we've got the, all the regulatory authorities have given us approval to open the sites up now. Now, it's individual sites will have their own processes as well, which they have to overcome, and then they can open the study. The study is open for at least 9 years, basically. So there is a long recruitment phase of around 6 years. And what I would suggest is that it's a continuous process. As soon as patients coming off the FLAIR study, hopefully we hoped that if we would have opened this study, say 2 years before, then it would be a seamless transition from FLAIR into static, but it's not been the case. So there would be a bit of an abrupt kind of restarting of this study. But I think overall, the patients who are in the 4th year or 5th year of their ibrutinib therapy, they won't see that, they don't need to stop the therapy, and hopefully the transition to this study, static study, would be pretty seamless in that scenario.
Mm-hmm. Good. And how would the study team keep those who take part in static up to date with how things are progressing?
Yes, so I think one of the things which I'm very grateful to the CLL support team is being highlighted to us, that I would be the first person to say that the communication about this has not been up to speed, and we want to communicate better about how the study is enrolling and how the things are progressing, if there is any changes that are happening. So what I can say is that we will be giving updates, and we will be using your platforms, the CLL support platform, to kind of inform where we are at this moment in time, and subsequently updates would be coming through. I think if you have any specific question, you can always come through to the Leeds CTRU webpage, and I think we'll try to answer any questions that you have. But I know it has been a difficult time for all of us, and hopefully we can improve the communication with the trial participants.
And I know this won't be a short-term answer, but when might you expect the first results from static?
I think it will take some time for us to get some results on static, but there are different questions that are answered on the study, and some of the answers are what we call as primary endpoint of the study. So what we want to see is, the main question in this study is whether intermittent strategy is the right one to do or not. And if our intermittent strategy is the right one, then we will know in 2 to 3 years' time some initial data which will be coming through, which essentially will tell us how many patients on intermittent strategy need to start therapy again. That's one of the main questions of the study, and then after that, once they restart the therapy, whether they go back into remission again or not. And I'm afraid the answers to those questions will take some time, but these are very, very important questions that we want to answer. And if we look at the data from other trials where ibrutinib has been stopped for one reason or another, we know that patients who achieve very deep remissions are not relapsing very quickly at all. And that is very reassuring, but that gives us another food of thought whether we need to continue continuous therapy in patients with very good deep remissions. And that's exactly what static is trying to answer.
Right. And I mean, while in general, what you're saying applies on average, of course, there'll be individual situations where people have had very different experiences. And I think we obviously need to recognize that. If I could ask you some questions about ibrutinib, which seems to be a source of lots of queries. First of all, Peter referred to the nail issue, and somebody wants to know, can you just elaborate on that a little, please?
Yeah, so ibrutinib can cause nail issues because ibrutinib is a drug which blocks this protein called the gluten tyrosine kinase, and that is what I call it as a signaling protein from the CLL cells, and it transmits the signals into the DNA or the nucleus. And when we block this BTK, obviously we are stopping those signals going to the DNA. And the main thing is that it stops the cells from dividing quickly, and it also shifts the cells as well from the lymph nodes and the bone marrow. But one of the other side effects of this drug is that it not only blocks this BTK, but it blocks some other kinases in the body. And some of those kinases are present in our nails, sometimes in our skin as well. So what I tell my patients is that your nails might not grow that quickly. And sometimes you get, cracking of the nails as well, which is a known side effect of ibrutinib. Not everybody gets it, but some people do get it. And if you do get it, most of the times sometimes it's manageable. Sometimes if the side effects is bad enough, dose reduction is sometimes needed of ibrutinib, but do talk to your clinician about it. There's some evidence that zinc supplementation helps in that scenario as well.
Oh, thank you. So what length of time is the funding for ibrutinib available in the static trial?
So yes, it's going to go on for at least another 9 years. This therapy, so there's a long-term funding available for ibrutinib in this study, and so we will be expecting that this would be sufficient. But if there is anything else that we need to do about it, then we will definitely keep you up to speed with it. So as we discussed before, that maybe a quarterly update about static and informing you about these things would be useful for everybody.
Good. So just for everybody else's benefit, Tal has very, very kindly offered to work with CLL support to make sure we can bring you regular updates with what's happening with the static trial. So I'll just explain what he was alluding to there. So if participants get to the end of the static trial, there won't then be automatically ongoing access to ibrutinib, as was the case with FLAIR. Is that correct?
Yeah, at the moment, it is true, but I think we would have, if somebody's on ibrutinib for 6 years and then we have another, substantial number of years on ibrutinib, then that would be fantastic if somebody can stay on it for that length of time. But at the same time, yes, if we come to the end of the study and we feel that the patients would need ibrutinib, then yes, I think we will try to make every effort to get access to ibrutinib in that setting as well. But like what happened with FLAIR study, when we were conceiving the study, it was 2012, and at that time ibrutinib was not available. Nobody knew how this drug will pan out over the next few years, and clearly it was a game changer for majority of the CLL patients.
And we've got some very well-informed people on the call. So one of them understands that the patent for ibrutinib ends in December 2026. So will the trial only use branded ibrutinib? Or if not, would this complicate standardization of the trial?
I think we will be getting branded ibrutinib because we have got the contracts with the Janssen, which is the company sponsoring the study. So I can reassure you that that would be the case.
Okay, thank you. And one of the earlier versions of the protocol mentioned any other BTKI. So this trial is about ibrutinib. It's not about a calibrutinib, or it wouldn't be in the future. Okay.
This is something we will have to look at. I think what will happen over time is that if we have got a number of patients on acalabrutinib as well in the UK, and this question would be pertinent to those patients as well. So if at any time point we have to amend the trial or try to include those patients into this study, or offer another study with similar design or similar concept, then we will let the participants know. But at the moment, this is just for ibrutinib treated patients, and this does not involve other BTKI inhibitor therapy. And I'll be honest with you that the primary reason is that a lot of our patients on FLAIR study has been on ibrutinib, and we wanted, those patients to get onto this study, but also the patients who have had ibrutinib for a long time can go into this study. But needless to say that if we need to change anything and allow a calibrutinib treated patient, or there are some patients on a drug called zanubrutinib to come on board with this kind of study, then we will look at all of those questions at some point, but not at this moment in time.
Fantastic. And the continuous versus intermittent, the philosophy of that, if you like, that could be applied to other drugs such as acalabrutinib in the future. Is this what you're...
Yes, so if it was for me to include everything, then I think I would include that any BTKI inhibitor into this basket. But the reality is that the way we are conducting the trial at the moment, we are in the situation that ibrutinib is made by one company and then acalabrutinib is made by another company. So it makes it difficult to kind of conduct such a big study with with the help of multiple pharma. So I think what we will end up doing in the first place is looking at the question with ibrutinib, and say, for example, we get the results that this strategy is the right one, then we will publish the results, and that can be applicable to other BTKI inhibitors as well, because they work in a similar way, and the design of the study is such that it will help us to ascertain whether intermittent therapy is the right way to go, and acquisition of resistance, which is one of the main problems with the drug continuous therapy, can be applicable to other BTKI inhibitors as well.
Mm-hmm. And just 2 or 3 questions, if I may, about reporting results. So what results will you be asking participants on the trial to report?
So there would be questionnaires that would be asked from participants individually when they come for their individual visits. So these are most people who are participated in FLAIR would be used to them. So there is patient health related questionnaires, which gives us a scoring system and tells us how well the drug is being tolerated. So those questionnaires will pretty much be the same as what we were using in FLAIR study as well. Yeah, those are the main things really. There's what we call as PROs, or patients reported outcomes. And that is very, very important part of any study to, we want to see the clinical improvement, but then we also want to see that the outcomes for the patients is better as well, and they feel better on the drug as well.
Fantastic. And would those reports be submitted through an online portal, mobile phone, tablet, laptop? How would it happen?
I think at the moment they're mostly paper form, but
Okay.
some of they are being transmitted onto the tabs and iPads and other things. But the issue with that is that there is GDPR rules and other things which we need to make sure that we are compliant with. So it opens up a different conundrum for us how we manage that. And I must be honest with you that my fantastic trials team in Leeds are the best people who will look into that, so that we are not we will try to make it easy, but we have to be compliant with GDPR and make sure that we are not doing anything wrong here.
Right. And I'm just looking at the most recent questions that have come in. If people on the FLAIR trial are on an arm that involves taking ibrutinib with, say, venetoclax, would that continue, that combination into static?
So I think some of the patients who will be on ibrutinib and venetoclax arm of the study on FLAIR, some of those patients have already stopped therapy, depending on the minimal residual disease response. Some of those patients will continue ibrutinib and venetoclax for 6 years at least. And those patients, I think if they still have got some disease left, and I'm hoping not much disease will be left over at 6 years, then those patients would be allowed to go into static study at that point if needed. But that is, I'm hoping that the disease will all disappear with that combination.
Thank you. And is there a difference between unmutated CLL and mutated CLL when treated by ibrutinib?
So in terms of mutated and unmutated CLL, we know that unmutated CLL patients don't benefit much from chemoimmunotherapy. They benefit from chemoimmunotherapy, but the response is not that long with chemoimmunotherapy. What we found in FLAIR study was that the ibrutinib treated patients, whether they had mutated IGHV or unmutated IGHV, they were benefiting from ibrutinib in both arms of the study. And there's some evidence to say that unmutated patients actually are benefiting more from ibrutinib, But needless to say that the mutated ones were also showing very, very good response. So when we stop therapy at 6 years time point, we will be stratifying, and this is a term used. It's in trials based on the mutation status based on IGHV, and we will see whether unmutated patients tend to start to show the disease coming back quicker as compared to the mutated patients. But that is a question that we want to answer in static as well.
Right. And I've got a question here about, just coming back to ibrutinib. Might there be research into whether it should be ramped down slowly and not suddenly withdrawn at some point? Because some people are saying if you just cut it off, then there could be a very quick relapse.
Yeah, so that's where the question about active disease comes into play. What we feel with FLAIR and our data suggests that if somebody has taken ibrutinib for 6 years, the amount of disease in the bone marrow and in the blood is very, very low. And if we stop at that point, what we have found from some other studies as well, that the disease relapse doesn't happen for at least up to 21 months in some studies and up to 2 years in some studies as well. Now, that is different if somebody is taking ibrutinib for 1 year or 2 years. If you stop at that point abruptly, the disease comes back very quickly. And in some patients, I know that I've stopped treatment for another reason, like some kind of a procedure, and suddenly you stop and the lymph nodes are back in. And that just tells you that we've stopped the therapy very, very quickly. And that usually happens in people who have got relapsed refractory disease rather than frontline CLL. So that's why in relapsed refractory CLL, we are choosing at least 3 years of therapy with ibrutinib before the patients can go into study. If you start venetoclax, you don't see that kind of rebound at all. That's not a problem.
Thank you. And I can see there are lots more questions, but we obviously haven't got time for them all today. But if individuals wanted to see the trial protocol, how could they access it?
So you can, your site will have it, but also the lead CTRU team would be able to provide the details. The issue with the trial protocol is it's very complex and it's very tedious to go through 150 pages of the protocol.
I know, I've read it.
And the most important one is the patient information sheet, because that is written in very clear words. But if somebody wants to look at the protocol, that's not a problem. You can contact the lead CTRU team.
Fantastic. And I'm sure lots of people on the call will want to know, what questions should they be asking their consultants and other medical advisors if they're interested in going on the trial? What's the best way to start a conversation about that?
So I think most of the clinicians, and I will be talking to the participant of most of the investigators in a FLAIR study at some of our UKCLL forum. There is some meetings where I will be telling them that the trial is open now and they should try to open the study as quickly as possible in their sites. I think when you go and see the consultants ask the question that, I've got 6 years of therapy now, I'm coming to that point, or I've stopped the therapy. I know that static is opening up now. What is the timeline in your center and how quickly it's going to open? And most of the clinicians will be able to give you some kind of idea when the trial is going to open at your site. I presume it's we are having this forum now here at the moment, and most people who are interested in static are listening to me. But I think at the same time, we will spread the word to all the sites, and actually there is notification which goes out from lead CTRU to all the sites in FLAIR that the trial is open now, and there is they should try to open. So there is notifications going out all the time. So yeah, please get in touch with your trial nurses, get in touch with your investigators, and hopefully I'm pretty sure they will answer you appropriately, and I'm hoping that most sites will open as quickly as possible.
Fantastic. So, Dr. Munir, if I can be formal, thank you so much for being with us today, and please pass on our thanks to Professor Hillman.